All right, so this is lecture 3.2, our main lecture, and we're looking at types of studies. Purpose of this week is to analyze the types of studies utilized in epidemiologic research. So this week, you're going to be doing a response to the discussion 1 that you did in week number 2. And I'll talk more about this at the end of the lecture. Again, you're going to be providing a response and basically trying to help individuals formulate ideas. Some of the best work that I think I've done has come from having conversations with people that have brought different things to the table. And that's really, I think, elevated at times some of the work that I've been able to do. You also have a homework assignment, which is going to be due at the end of the week on Sunday. And you'll need to, of course, have listened to the screencast as well as completed, or it's not completed, reviewed the articles by Mitch Rao et al., Powell et al., and Hootman et al. So epidemiologic studies, they can be classified as either being observational in nature or experimental. This table comes from the textbook, and so you can see a breakdown of different types of studies under the observational category and the experimental category. Another way of thinking about them is as experimental or non-experimental. And under experimental, yes, randomized controlled trials can definitely have epidemiologic components to them. Under non-experimental, we've got the observational epi, which would include our cohort studies and our case control studies. And then there can be descriptive epi, and some of those are listed there. So we're going to explore these based upon these categories from your textbook. Again, this and this are basically saying the same thing. Now, an observational study, this is a study that allows nature to take its course. So here we see the individual falling off of the treadmill. As an epidemiologist, you don't interfere in that process. You may assume that it's very stupid to try to go backwards on a treadmill, and you'd be right. But the epidemiologist does not interfere. The epidemiologist tries to look at the rate of injury and the types of injuries associated with running backwards or side to side on a treadmill. Now, there is descriptive and analytical types of observational studies. Descriptives limited to a description of the occurrence of the disease, and an analytical one starts to analyze relationships. Now, most studies are analytical in nature. Often, there are descriptive presentations within analytical studies. A purely descriptive observational study, this is limited to a description of the occurrence of disease in a population, and it is often the first step. Now, shown on this slide is a paper by Hootman et al. Looking at the epidemiology of collegiate injuries for 15 sports. This paper is descriptive in nature by presenting the occurrence of disease, or in this case, the occurrence of injury, but there are also some analytical components to it. Here's an example of a purely descriptive epi study. This was a case series published back in 1981 in the New England Journal of Medicine. And it is one of the first papers that explored the disease that was later known as AIDS. And so if you think about 1981, no cell phones, no internet per se, how are things communicated exclusively? Well, not exclusively, but a primary way of communication would have been through the dissemination of findings in research journals or the presentation of findings at a conference. And so this, again, was one of those first papers, descriptive in nature, not trying to be analytical, not trying to explore the potential way that the virus was transmitted, but just seeing that there was this presentation that was unique that people were not accustomed to. So again, these are a first step in epidemiologic investigations. The pure descriptive study makes no attempt to analyze the links between exposure and effect. These types of studies will do things like report mortality rates, injury rates, maternal death rates, things like that, just the rates that are being observed. There might be an examination of patterns by age, sex, or ethnicity, but again, it isn't analyzing beyond that. Here's an example of a descriptive study presented in your textbook. This is the maternal mortality observed in Sweden since the mid-18th century. And what it illustrates is a downward trend in maternal deaths over time. Now, what this allows one to do is to speculate potential causes. Is it a factor of better hospitals, better birth centers? Is it a factor of understanding things related to diet? You can start to speculate. You can also wonder, well, why was there an uptick after a substantial decline for a while? Was that associated with a period of famine or war? Here's another descriptive study example. This is comparing age standardized death rates from heart disease among men 30 years or more between 1950 and 2002. And you see in many of these first world countries, USA, Australia, United Kingdom, Canada, that there was a decrease that started to occur mid-70s and continued to drop into the 2000s. So it's presenting death rates. It also presented death rates in Brazil, and it presented information from the Russian Federation. So what's fascinating here is now if you are interested in studying the men living in Russia, you might wonder, okay, why has there been no change there? Does it have something to do with their diet? Something to do with alcohol consumption? Something to do with access to healthcare? You could start to explore that. You can see that these first world countries started to have decreases down to the point similar to where Brazil had always been at. Well, why was Brazil always low? Was it something to do with awareness of smoking in the 70s? And then public health efforts to help try to curb that behavior. Again, no analysis or analyzing is presented in this information. It just gets you to start to speculate, to hypothesize. Looking at ecological studies, these are also known as correlational studies. These are useful for generating hypotheses. The units of analysis are groups of people rather than individuals. So an example described in the textbook is a relationship between the average sales of an anti-asthma drug and the occurrence of an unusually high number of asthma-related deaths. Now, if that relationship happened, the observation would need to be tested by controlling for potential confounders to exclude the possibility that other characteristics did not account for the relationship. So why were there more deaths when people had access to medication? Ecological studies can also be done by comparing populations in different places at the same time or in a time series by comparing the same population in one place at different times. So here's an example. This is a daily time series showing deaths in France during the 2003 heat wave. There was a correlation between increasing temperatures and increasing numbers of deaths. We were able to see the number of excess deaths per day related to the temperature ranges. We don't know why those deaths occurred. Did individuals have a lack of air conditioning? Were they older adults, or were they individuals of all ages? Were they individuals who had underlying medical conditions that put them at greater risk? The strengths of ecological studies, they are simple to perform. Weaknesses, they're difficult to interpret, seldom possible to examine directly the potential explanations for the findings. Often these studies rely on data collected for other purposes. Data on different exposures, on socioeconomic factors may not be available. So people have information, but they may not have all the information that you might want to be able to look at. The unit of analysis is the group, so a link between exposure and the effect at the individual level may not be able to be made. Now, what is a potential bias or fallacy related to these types of studies? Well, the results, if inappropriate conclusions, this will result if inappropriate conclusions are drawn on the basis of the data. Bias occurs because the association between variables at the group level does not necessarily represent the association that exists at the individual level. Here's a bias example. And what we see here, Europe, the Americas, Western Pacific, and then Eastern Mediterranean, Western Pacific without China, then some Asian countries or Asian regions, and Africa. And what we see here, the boxes are the percentages of births without a skilled attendant. And so, okay, that makes sense. Some of these areas may not have the same medical availabilities as other countries. Then they show overlapping lines for maternal mortality and neonatal mortality. And so what we see is lower numbers, Western areas, and then we see it spike up a bit for Eastern Mediterranean and then drop down a bit for South or Southern Asia. Let me see exactly which one that is. Move this over, Southeast Asia without India. And then we see these big spikes up for Southeast Asia and Africa. So is it that a lack of skilled birth attendants is the explanation? Well, we see some lower ones here. They're still higher than the Western ones. But we also see there's some really high ones. And so it may not be that skilled birth attendants is the only explanation. I had a chance to visit, well, not visit, I did a medical mission trip this past summer to Uganda. And of course, Uganda is just one country in Africa, but it is a pretty poor country with a general lack of healthcare services. And, there's, I think, 48 million people in a country the size of Oregon, where I live. Oregon has about 4.5 million people. So they don't have a strong medical system in place. So that's one factor. But I also then observed people not having a lot of resources for food, for diet, right? And I saw people that were living in conditions that we would not expect to see in the United States. And so is there exposure to viruses? Are there lots of different threats to people having a successful delivery in Uganda compared to other areas? Cross-sectional studies discussed these last week. It's a measure of the prevalence of disease or injury or outcome of interest, typically at one point of time. Of course, you can have serial cross-sectional studies too. Question being, does the exposure precede or follow the effect? And then again, I gave these cross-sectional study examples looking at the prevalence of steroid use among Major League Baseball players, and then, of course, made-up data showing an increase over time. Prevalence studies or these cross-sectional studies are valuable for planning health services, and they provide valuable information about what to expect in different clinical situations, and they are less time-consuming and inexpensive. They are only weak evidence, though, for cause and effect. Case control studies, these provide a relatively cheap way to investigate causes of disease or injury, especially for rare diseases. Now, recall in a cohort study, which we talked about last week, an incidence study, the study may not be able to capture enough people for that rare condition, or you may have to wait forever for an occurrence. Again, a cross-sectional study may not be able to capture that presence of a rare disease either. This is where a case control study has benefits. These studies include people with the disease, or outcome variable of interest, and a control population, so a reference group that does not have the disease or the outcome of interest. This type of study compares the occurrence of the possible causes in cases and controls. Researchers collect data on disease occurrence at one point in time and exposures at a previous point in time. So with this, you want to have a selection of cases and controls. The cases are selected based upon disease presence. They're not selected upon the exposure. Controls are people without the disease. The most difficult task is to select controls so as to sample the exposure prevalence in the population that generated the cases. Here's what this looks like. So the population here, basically, maybe this is like Oregon, and then maybe the cases, maybe I go to the big teaching hospital where you've got specialists in cancer and in cardiac disease, things like that. So this is the place where people go, Oregon Health Sciences University, to work with those doctors who are specialists and knowledgeable. And then what you would do is find controls, people without the disease, people that are similar in many demographic age, ethnicity, or race. Maybe where they live. And then you go back in time. So you basically ask them, or you look at their medical records, and do they have certain exposures? That's a great way to figure out maybe if something increases the risk of cancer. So if you think about something that's associated with pesticides or agricultural chemicals, is a cancer related to exposure to that? Because that would be valuable to know. Here's another case control example. Researchers in Papua New Guinea compared the history of meat consumption in people who had enteritis necroticans, I think I pronounced that incorrectly, apologies, with people who did not have the disease. Proportionally, more people had the disease, reported prior meat consumption than those who were not affected. So how do they find this information? Again, you've got your population, people with the disease, people without the disease, and you ask them about behaviors, about habits, about exposures. So interviewing. Another case control example discovered the relationship between thalidomide and limb defects in babies born in Germany between 1959 and 1960. The study compared affected children with normal children. Of the 46 mothers whose babies had a malformation, 41 had been given thalidomide during weeks 4 and 9 of the pregnancy. None of the 300 mothers in the control group had taken the drug. And so it was important in that interview process, to know not only if they had taken the drug, but when the drug was consumed. That was crucial for determining relative exposure. All right, so we're about 19 minutes in. We're going to pause this one here, and we'll continue on in part 2.